Welcome to the web seminar on regulatory changes. I'm Joe Tamaro, and I'm the Senior Vice President at Accelero Health Partners. Joining me today is Michelle Bianco, Vice President for Operations for Accelero Health Partners. While a lot has been said and written about healthcare reform models, in the next 12 months, many of these models will become reality. Today, we would like to share with you the Inpatient Prospective Payment Update for acute care hospitals, also an update on quality initiatives, and an overview of a recent bundled payment model by the CMS Innovation Center. In August of 2011, Medicare released the 2012 guidelines for inpatient acute care hospitals. Hospitals overall will experience a base rate increase of 1%. That is good news, but when we go through specific musculoskeletal DRGs, you will see a different story. Also, the recent Budget Control Act mandates that over $1.5 trillion is needed to be cut from the overall federal budget. The impact on Medicare in the next 12 months is not known at this time. However, it could range between no payment cuts to as high as a 2% cut in reimbursement. This table demonstrates the relative weights for the major joint replacement DRGs over the past 5 years. Keep in mind that hospital payment for a DRG is a combination of the relative weight of that DRG along with a base rate. The most important thing to note on this table is that the relative weights for DRGs 469 and 470 decreased nearly 1% when comparing 2012 to 2011. This table shows the reimbursement trends for joint replacement DRGs over the past 5 years. For all of the tables, a large urban base rate was used to allow for comparison between years in different DRG groupings. For DRG 469 and 470, even though the relative weight decreased by nearly 1%, because of the base rate increase of 1%, the overall impact of reimbursement is negligible. This is the first time in over 10 years that there has been no increase in reimbursement for major joint replacements. This same methodology was used to evaluate reimbursement for the most common surgical spine DRGs. There are only slight increases in reimbursement for DRGs 459 and 460, which are lumbar fusions. Cervical fusions are a mixed bag. Payment decreases are occurring for cases with MCC, major complications and comorbidities, and moderate increases for cases with CC or without MCC or CCs. Non-fusion procedures have a moderate increase, with those procedures without complications and comorbidities or major complications and comorbidities having a greater increase. Looking at the same trends for fracture care, you can see that there are increases in both DRGs 481 and 482, continuing this upward trend in Medicare reimbursement for hip fractures. Although DRG 480 is slightly down, this needs to be balanced with substantial increases from $3,000 in 2008 to over $17,000 over the last 2 years. In addition to changes in relative weight, on an annual basis, Medicare updates the geometric mean length of stay, which determines how payment is allocated over the hospital stay. This table shows the geometric mean length of stay for the major joint replacement DRGs over the past 5 years. For the highest volume joint replacement DRG, that is DRG 470, the geometric mean length of stay has gone from 3.7 days to 3.3 days over the past 5 years. The most important part of this change is with regard to reimbursement. DRG 470 is a transfer DRG. That means that the hospital's payment varies depending on the length of stay and post-discharge destination. For 2012, in this example, the hospital's payment portion for Day 3 is $980. The Day 3 payment was $1,500 in 2010. It decreased to $1,250 in 2011, and now is down to $980 in 2012. The Day 3 payment has progressively decreased as the geometric mean length of stay has decreased. So this payment of $980 for Day 3 is in many cases the bed day cost for a hospital. Depending on your bed day cost, the additional reimbursement for the third day may be a break-even for the hospital. This, along with other factors, will continue to drive more 2-day lengths of stay for total joint replacement patients. This same trend is occurring for all 3 hip fracture DRGs, DRG 480, 481, and 482. For 2012, if your DRG distribution for hip fractures was that of Medicare, your blended average length of stay for a hip fracture patient should be 5.3 days. Since this patient population is largely Medicare, continued emphasis should occur on length of stay management with a consistently decreasing geometric mean length of stay for this particular grouping. CMS also has mechanisms for payers and providers to request changes in DRG assignment. 2 such requests were ruled upon in the Medicare 2012 inpatient guidelines. One request came from a manufacturer that requested that both cervical and lumbar spinal disc procedures be moved from a lower-paying non-fusion DRG to higher-payment cervical and lumbar fusion DRGs. This request has occurred multiple times over the past few years. CMS again rejected this request since disc replacement is a very low-volume procedure, especially for Medicare patients, and in many cases it's a non-covered procedure in certain geographic jurisdictions. There was also a request from joint replacement providers to add a 3rd complication level to the primary joint replacement base DRG. Currently, this base DRG has only 2 DRGs, one with MCC and one without CC or MCCs. CMS has a very defined process for these types of requests. It begins with examining historical data so that they can look at variations between these 3 levels of complications. Medicare examined the 2010 records and classified primary joint replacements in those 3 categories: MCC, CC, or no CC/MCCs. The table shows the cases in each category, the variability in average length of stay, and the variability in total cost between those 3 levels. You can see that there are clear differences between cases with major complications and comorbidities and those without. Hence, the separate DRGs for those cases with major complications and comorbidities. There are also subtle differences between average length of stay and total cost between cases with complications and comorbidities and those without CC/MCCs. CMS has a defined criteria that must be met to add a CC or MCC subgroup. This includes both having a substantial number of cases in a subgroup and a significant percentage and absolute cost difference between the 2 levels. So using this criteria, CMS rejected the notion of a CC subgroup to the joint replacement-based DRG. However, what should not be lost in this exercise is the notion that cases with complications and comorbidities have an increased average cost of over $1,000 as compared to those without complications and comorbidities. However, there is no additional reimbursement for those types of cases. This point emphasizes the need to continue to understand quality metrics and changes. Michelle Bianco will expand upon these.
Quality measures assess structural aspects of care, clinical processes, patient experience, and increasingly, patient outcomes. In this section, I will be outlining the changes for fiscal year 2012 to inpatient and outpatient quality reporting. As you can see, CMS has updated the names of the inpatient and outpatient quality reporting program. Again this year, CMS has increased the emphasis on quality reporting measures. There are 2 significant subsets of quality indicators for hospital services: the Inpatient Quality Reporting Program and Value-Based Purchasing. The Hospital Inpatient Reporting Program is intertwined with Value-Based Purchasing, as currently the measures overlap. Inpatient quality reporting initiatives are reportable, and many are showcased on the Hospital Compare website, which encourages consumers to choose healthcare based on publicly reported quality measures. Value-based purchasing is intended to promote high-quality, safe, patient-centered care while reducing costs through the efficiency of care and avoidance of preventable adverse events that not only increase the burden of illness on the patient, but also greatly increases healthcare spending. The measures under the value-based purchasing program must be selected from those measures specifically defined under the Inpatient Quality Reporting Initiative. This paradigm shift of financially rewarding hospitals for better value and outcomes is transforming Medicare into an active purchaser of quality health care for its beneficiaries. As a reminder, value-based purchasing will apply to payments for discharges occurring on or after October 1, 2012. The reward payment is funded through the gradual reductions in DRG payment for each discharge. Hospitals will have the opportunity to earn the financial deficit back through their performance on outcomes and patient experience weighted measures. To orient you to this table, the current slide and several subsequent slides outline the hospital inpatient quality measures and the submission time period. It also denotes if the measure is used for CMS, Joint Commission, or both, and the release date for the measures to be transparent on the Hospital Compare website. I will not be discussing each measure, but these next several slides can be used as a future reference document. AMI and heart failure measures are outlined on this slide. Several pneumonia measures are reportable on Hospital Compare. With the exception of temperature management, all SCIP measures are reportable on Hospital Compare and are collected by both CMS and the Joint Commission. A recent study by AHRQ in Health Affairs highlighted that when a VTE occurs, it increases cost of care by 25%. Many of these measures are collected for Joint Commission, but the 6 VTE measures are currently being proposed for CMS collection starting in 2015. HCAHPS scores are being tracked and reported for CMS and have a weighted impact on value-based payments. This continues to emphasize the value of the patient care experience on your reimbursement for hospital inpatient reporting. Structural measures continue to be emphasized to enforce quality measurement. Readmission rates for AMI, pneumonia, and heart failure are all reportable to CMS. Patient safety indicators and inpatient quality indicators continue to be earmarked for measurement through 2015. Many of these measures will now be available on Hospital Compare to allow transparency for the healthcare consumer. Hospital-acquired conditions have been added for 2012 inclusion in the Inpatient Quality Reporting Program. CMS has proposed to add one new category. Acute renal failure after contrast administration has been proposed to be added to the list of measures. Due to challenges with coding, though, CMS is deferring adoption of the hospital-acquired condition. Of note is the addition of codes for DVT and PE following certain orthopedic procedures. These include joint replacements for specifically saddle embolus of the pulmonary artery. You can see a detailed list of reportable hospital-acquired conditions. As I mentioned, there have been a few additions for DVT and PE for joint replacement patients and other orthopedic procedures. Most importantly, you need to ensure that you have a process in place to not only measure and track, but improve these hospital-acquired conditions within your hospital program. In summary, a few changes occurred for the 2012 inpatient quality reporting measures due to public comment. Measures related to adult smoking cessation are being retired due to no longer being National Quality Foundation, NQF, endorsed measures. They are also topped out, which provides assurance that these processes are incorporated into routine hospital care. With respect to the pneumonia measure, there is concern that the tracking of this measure may result in the unintended overuse of antibiotics. There is an increased burden on hospitals for chart-abstracted data, and CMS is being sensitive to this. The suspended measures will continue to be retained in the hospital inpatient quality reporting program, but data